So today I'm going to talk a little bit about maternal health specifically and draw on some of the work that Michelle has also presented today, but take us on a kind of a global sense of why maternal health matters and why if you don't have maternal health, you don't have healthy babies and you don't have healthy communities and you don't have healthy countries. But sadly, in many places, mothers are the last ones that get thought about. So why maternal health matters? I saw up before there was a quote by Hillary Clinton, who's a bit of a hero of mine at the moment, hero. One of her good quotes is, "You cannot have maternal health without reproductive health," and reproductive health includes modern contraception, family planning and access to legal safe abortion. Things that are a bit tricky to talk about in some communities, and particularly with some of the funding issues at the moment around the global gag rule, which I'll come back to. So let's start with some quick facts. Nearly 830 women will die today in the world due to complications due to pregnancy and childbirth. And while we have lunch today, that'll be 70. So that's 2 A380s a day going down. So whenever I get on a plane, I think about, I try not to think about the plane going down, but sometimes I do, and think about, imagine if 2 of these went down every day. Imagine how shocking that would be. So 23 women die in Australia each year, 23 too many given our very groovy health system, but 1,500 women will die each year in Papua New Guinea. That's probably an underestimate because it's a huge challenge to work out maternal mortality rates. Women die in pregnancy and childbirth for 5 main reasons, and sadly those 5 main reasons have kind of been the same for a very long time. So women mostly die of bleeding after their baby's born, infection, usually after their baby's born, unsafe abortion and hypertension. And in Papua New Guinea, those 4 causes themselves account for about 80% of deaths of women. When a mother dies, her child is more vulnerable, her children are more vulnerable. And I took this photograph in a cemetery in Timor-Leste, which was one woman and her 4 children. And her grave was a little bit further along, if I could work out the names. When a mother dies, her children are much more likely to die than survive. Children are more likely to be abused, given chores and stopped attending school, especially if they're girls. So girl children are particularly vulnerable. And about 16 million girls aged between 15 and 19 give birth each year. Adolescents account for 10% of all births in low and middle income countries, and they are the leading cause of death for 15 to 19-year-olds. So those of you in the room who have an adolescent girl at home, that's a pretty shocking thing to think about, that might be the leading cause of death if that young woman became pregnant. And maternal health mirrors the gap between rich and poor in our country and in every other country in the world. Maternal mortality is higher in poor countries, in rural communities and in less educated communities. Less than 1% of the maternal deaths occur in high-income countries. So the maternal mortality ratio, which is what we kind of use as the benchmark, the MMR, in developing countries is about 240. In richer countries, it's about 12. Currently in Australia, it's 7, unless you're an Aboriginal and Torres Strait Islander community, and then it's about 13. But that's still a very big difference to what it is in most parts of the world. And the sad reality is most maternal deaths can be prevented. Most maternal deaths may not happen at all. They need a skilled birth attendant. I think Freya mentioned having someone, you had quite a troop of people with you. Most women in the world don't. Antenatal visits, we used to recommend 4 antenatal visits. The World Health Organization last year recommended 8. In countries like Papua New Guinea, getting to 4 is almost impossible. Getting to 8 is going to be nigh on impossible. Appropriate care and screening, and you've heard some of the work that's being done through here, particularly around screening for sexually transmitted infections, prevention of mother-to-child transmission of HIV, giving women appropriate treatments for anemia, and things that we do after the baby's born to help the health of the baby, but also the health of the mother, skin-to-skin contact and breastfeeding. These are very simple things that can be done. 22 million abortions continue to be performed unsafely each year. And whatever we personally feel about abortion, and it's a difficult subject, it's real and it happens. And in many parts of the world it happens in very unsafe, unsterile circumstances. And not only unsafe in terms of bleeding and infection, but unsafe in terms of what happens to women in terms of violence around the pregnancy and the decision to have an abortion. In many countries, including Papua New Guinea, women get put in jail for having had a termination of pregnancy. And we haven't done well enough reducing the maternal mortality ratio. The Millennium Development Goals aim to reduce the MMR by 75% from 1990 to 2005. Most countries, most low-income countries, didn't make it. Most countries, globally, we declined by 2.3%, but to get to that number, we had to decline by 5.5%. So accelerating is a big challenge and requires a significant commitment to understanding the problem and then instituting health systems reform to make a difference. Quality care, a health workforce that functions, access to drugs and commodities, and a functional health system. And these are very challenging things in places like Papua New Guinea and in many parts of the Pacific and across the world. And as I said, lack of skilled care is the main obstacle to better health for mothers in many countries. WHO forecasts an 18 million shortage of qualified health workers by 2030. That's over twice the 7 million shortfall we estimated a couple of years ago. So more people, more health required, less health workers being employed, less health workers being trained. So I just want to take you on a couple of global realities, and Michelle and Freya have talked a little bit about the reality, but this is a photo taken by my colleague Lisa Vallely in Papua New Guinea. It's in the highlands rather than in Kokopo. This is the reality of the place of birth for about 43% of women in Papua New Guinea. This woman was giving birth on the side of the river. The river is empty, as you can see, which is probably just as well. But she had taken herself down from the village, which wasn't very far away, in labour alone. So in many parts of the world, women give birth alone, both in a facility, but also in villages, in rural areas. She was in labour and Lisa could hear her crying out and went to her. It was obvious, Lisa's midwife, was obvious that she was having a baby, and minutes later this baby was born. So imagine if that was your best option. You're in a rural area, you're in labour, it's probably 2 days walk to the nearest health facility, you don't have a road, you don't have a vehicle. And in some of the research that I did with Lisa around that time, even if you did have a vehicle, the men in the village didn't want to use the petrol to get you to hospital, because actually women are not that valued. If we don't value women, it has a whole lot of trickle-down effects. So what's happened in many countries is we've encouraged women to go to hospitals, but this is what the hospital looks like in lots of places. The harsh reality of a hospital, this is in India, but it's not that dissimilar to lots of places. Imagine being this woman or being her mother or her sister. You wouldn't know if you were a mother or a sister because you wouldn't be allowed in. You would be sitting on one of the benches outside the labour ward waiting to someone maybe to come and tell you that the baby had been born. But many women go to these sorts of facilities. You can see the floor is dirty. She doesn't have a blanket, she doesn't have anything to lie on. She's got an IV pole, that's the metal pole, which possibly should have an IV hanging on it to resuscitate her, but there's nothing there. And the floor looks pretty grotty and very dirty. So no wonder women choose to stay at home. If that was your alternative, I would certainly be staying at home, and possibly the river would look like a better option. Now I'm going to show you a few maps of the world, which look a bit different than the maps you're used to seeing. It's called World Mapper, and it rescales the world according to the item of interest. So you can see here where most of the people in the world live. This is total population. We're a bit tiny, we've kind of disappeared. But India's pretty big, China's pretty big, and you can see Europe is quite big compared to their land mass. Then we see where babies are born. So kind of places where there are lots of population and high fertility rate and not much contraception have a lot of babies. So again, India. But Africa's got bigger. because even though Africa in the last map was a bit smaller, more babies are born per woman in places like Africa. And you can see in our region it's kind of getting bigger. This is where we spend money on healthcare. So not in the countries where we were seeing the population or the births. We spend money in healthcare in the north. The global north has the money for the healthcare, and in many cases the global north controls the money that goes to the global south, which at the moment is a particularly big problem. And then where do women die in childbirth is a very starkly different map to where the resources actually are. Unfortunately, Papua New Guinea ends up being a bit smaller than it should because of lack of access to proper data on the number of maternal deaths. So child survival equals maternal survival, because having a baby survive means your next pregnancy is delayed. We know that when women lose a baby, they're much more likely to become pregnant quickly if they can. If they have their baby and the baby survives, they breastfeed, they've got access into the health system, they look for means to reduce or prevent the next pregnancy quickly. So they're much more likely to survive. And a woman cannot be a maternal death if she's not pregnant. So you just can't die of a maternal death if you weren't pregnant in the last 42 days or currently. And we know that access to modern contraceptives saves lives. Many of us have stopped talking about family planning because it denotes that there's a family, which if you're a 15-year-old, you might not think about the sex you're having as a family, and it denotes planning, and a lot of it isn't planned or planning. So I'm talking about access to modern contraceptives. Let's be real about what it is that we think that women should have access to. So the solutions, I'm not sure if you can see those little words, unfortunately, but the solutions are not rocket science. They're not that hard. Access to affordable care before, during and after birth. And affordable is critical in that. Out-of-pocket expenses, even in countries that say they have a health system, so I guess ours is one example, but we've just done a study in Ghana, and the catastrophic health costs that women had to pay to give birth were extraordinary, and meant in some rural communities women had no care whatsoever because they just couldn't afford the tablet or the test or a visit to the hospital. Access to quality midwifery and obstetric care, including safe abortion care, modern contraceptive I've already spoken on, and nutrition, education, support and breastfeeding. And Michelle and Freya have both talked about the issues around micronutrients and anemia and the risks for women, short-term and long-term. And a safe birth needs a safe pair of hands. This sounds like a nice, simple slogan. This came from UNICEF in the last week, but a lot is needed in the health system to have a safe pair of hands. High government commitment, valuing of women, and research. We need to know what it takes to get a safe pair of hands, and we need to know what they need to do once they're there. And then we need to work out for the health workforce how to keep them there, how to make sure that the workforce themselves are going to be valued and they'll be there tomorrow. In PNG, where I go a lot, the National Hospital has 16,000 births a year, and they have about 5 midwives on a shift. So that's 50 babies born a day. So Tanya Farrell's hospital down the road has 7,000 births a year and probably has about 30 midwives on a shift. That's just an order of magnitude. So we need to know how to save women, how to get them to health systems, how to get governments to better understand the problem, and then how to ensure that the system is safe and sustainable. So workforce is my area that I'm most interested in. I want to make sure that there are people to deliver the things that we discover communities need. You need to have a health workforce who's going to actually do it. So this is some work that I did for State of the World Midwifery Report. We looked at about 90 countries around the world, the poorest countries in the world, and worked out their health workforce that they had and what they needed for the future. And we could work out how much they had according to how much they needed. So you can, a higher proportion is better, obviously. So in Papua New Guinea, they have only 50% of the health workforce they need to be able to deliver the care to the women they've got. And in the Solomon Islands, it's only 30%. And that's going on a fertility rate that's currently the same. If the fertility rate goes up a bit, the numbers go down. And if the health workforce numbers go down a bit, the numbers go down as well. We're currently now doing that analysis across the Pacific in a number, in the 14 Pacific Island countries. So these are the women that are often left out of quality care, both in our country in Australia, but more importantly in countries in the region, and low to middle income countries around the world. These are the women who are too hard to reach, can't afford to come, too scared to come, or the services that they came to aren't any good or just aren't there anymore. Or they're just too difficult. These are the hard women. These are the tough women. And when you're in an overstretched service and you're a health worker and you're tired, these are the tough women that you just might not bother making that extra effort to go and see. So it's not all terrible. There are some great things going on around the world, and many work that's being done here, I think, is leading that way as well. So I'm working at the moment in Cambodia, and Cambodia's made some very big moves towards reducing maternal mortality. They trained hundreds and hundreds of midwives in the 90s, brought their maternal mortality rate down from 1,200 down to 161 at the moment. They want to get to below 70. But to get that, they have to have quality midwives. They've worked out a quality midwife in every health centre, in every village, with drugs, with a phone and with a motorbike, so she can get out if she needs it. So we're there helping support that work. In Papua New Guinea as well, there's been amazing work to try and build the health workforce and to ensure that women get access to healthcare, particularly in remote villages. We've been involved in doubling the midwifery workforce in PNG over the last 5 years, from 400 to 800, which is still nowhere near where it should be. But in many villages now, there's a midwife where there wasn't one before. And a midwife's a really cheap workforce. You have to train them, and you have to look after them, and you have to regulate them, and you have to support them. But once they're out there with those facilities, some simple drugs, as I said, and a telephone, they can deliver 87% of the interventions. They need the motorbike or the vehicle to get them to the hospital for a caesarean section, a blood transfusion, access to higher level drugs. But a whole lot of simple things can be done at a very simple level. So what more needs to be done in my last minute? Good quality healthcare, safe and respectful healthcare. It's a sad indictment that in many of the training I do, the first thing I say to midwives is, when you work with women, be nice to them. Smile. Be kind. If you're grumpy, they're not coming back tomorrow. And it's really sad that we have to say that, but we do. Universal health coverage. It's not okay that women have to go into catastrophic debt to pay for their childbirth. Financing, health system resilience, and better evidence, better research to help governments make good decisions about where to put money, better advocacy and better accountability. How can we leave no women behind? Support access to modern contraception, abortion and maternal and health programs. And Healthy Mothers and Babies is an excellent example of bringing all of those pieces of the jigsaw together. Having a better health workforce. Advocating for overseas aid. I know I'm absolutely speaking to the converted in this room, but I do speak at places where people are grumpy that overseas aid is going overseas, frankly. It's really important that we support our near neighbours in whatever way that we can. Gender equity, equality and education for girls, absolutely critical. And focusing on the most vulnerable and the most disadvantaged, the most hard to reach, the most difficult to care for, the most challenging to care for. And this is a quote from Melinda Gates that I really like at the moment. Healthy, enabled, empowered and valued women can achieve their potential and make substantial contributions to their families and their communities. If the health needs of women and the substantial problem of gender inequality are not addressed, no society or economy will flourish or achieve its potential. So, investing in girls and women. When we invest in girls and women, everybody wins. Girls and women carry more than babies or water. They carry families, they carry businesses, they carry potential. When we invest in their health, rights and well-being, it creates a positive ripple effect that lifts up entire countries. Give girls and women access to healthcare, they will deliver more resilient families. Give girls and women the chance to learn, they will deliver more stronger communities and economies. Give girls and women opportunities, they will deliver the solutions. And when we invest in women and girls, no one will be left behind. Thank you.